we need to understand this now. Are we going to look at minimum cognitive impairment? Are we going to look at TIAs? Are we going to brand him as a potential candidate for dementia and start him on ginkgo biloba? Or are we going to look at something like maybe there are points to say that this is pseudo dementia? So this is what I would probably look at as a process. So the first thing that I would like to ask in this guy are we dealing with a demented patient or a pseudo dementia patient? And if you are telling me this is dementia, then probably these are not there. Like, we do not know the onset of illness. The patient's relatives are complaining more about the illness than him. He doesn't have a normal language. You started with slurring of speech. His attention is not there. He is not attentive enough for your test, for whatever that you have done. And there is also inconsistency or consistency. See, in demented patients, usually they are consistent and reproducible in all the cognitive tests that you do. Whereas in pseudo dementia, they are inconsistent. One time you tell them to do something, you draw a circle or draw a clock, they will do it in one way, and the next time they do it in some other way. This is how you differentiate a psychiatric patient from a demented patient. Why am I talking about that? Because dementia is no longer just about memory. If you look at, I'm sure you're going to show a slide on DSM criteria for dementia. We are talking about cortical lobar functions that are being affected, like visuospatial. So their complex apraxias, and all this can be seen even in patients with mania, bipolar disorder. So you need to differentiate the two. Once you finish that dementia question, then you were always asking about that question, it was rapidly progressive. So are we right in thinking of Alzheimer's, or should we think of a differential diagnosis? So if you look at the question above us, then is the illness rapidly progressive or not? And if you look at it, it is less than 1 year, then medical students, I used to always look for shortcuts, and the shortcut that I remember was vitamins. What are the dementias that actually progress rapidly? It is remembered with the mnemonic vitamins, and the first one is vascular. That is why the speaker before me was also asking you this question: do you think it is a vascular dementia? Because he was asking you whether it was rapidly progressive. Do you think of it as a vascular? Then infectious. We have to discuss about infections. Yes, syphilis. Syphilis was rampant before, now probably HIV. Herpetic infections. We have now seen that patients with isolated intracranial atherosclerotic disease having herpes simplex or varicella infections, and we see them. Toxic, metabolic, alcoholic, vitamin B12 deficiencies. So vitamin. So A is autoimmune, seizure personality, psychiatric disturbances with dementia. Then malignancy with Mets. Then iatrogenic. Was this patient seen by a psychiatrist before for all his illnesses? And then neurodegenerative. And then finally systemic. Systemic includes seizures, hypertensive encephalopathy, and all that. So the first question that I would see when you are seeing this person, doctor, is it dementia or a pseudo dementia? And if you tell me it is dementia and you tell me it's rapidly progressive, have we made an attempt to look at any of these illnesses and see whether this could fit in? So what do you feel, doctor?
Sir, we did rule out HIV in this patient, and he had no prior psychiatric consultation or any drug history. And for considering CJD, the patient, there's one more feature of CJD, that is myoclonus, and this patient did not have that. So that is the reason why we consider it as dementia, sir, because even though it was rapidly progressive, this patient had lack of insight. Like as in pseudo dementia patients, you said that they would only come and tell their problems, but that was not there in our patient. And our patient also.
No, I'm sorry. I'm sorry interrupting you. Dementia patients usually don't come and tell their problems. It is usually the patient's relative who tell these problems more than the patient himself. It is pseudo dementia where the patient comes and tells their problems more. Just to interrupt that, but that is a point. The 5 of the questions that I've put here, I'll share these documents with you. If yes to any of these questions, then more likely to be a pseudo dementia rather than a dementia. Go ahead, please. I'm sorry I interrupted you. Go ahead, doctor.
Yes, sir. Like I said, like this patient's wife and son were the one who were telling his symptoms more than the patient himself.
Exactly. Good. Go ahead. So you made a diagnosis of dementia, and you also know that it is a rapidly progressive dementia, which we do not know the cause. Now, why I'm stressing on this is, as much as we are looking at Alzheimer's, frontotemporal dementias, and vascular dementias, there are some rapidly progressive dementias that are potentially very easily treatable. like a normal pressure hydrocephalus or a vitamin B12 deficiency, even HIV for that matter. We have to look at clinicians. See, whenever I make a diagnosis of dementia, or if I tell my medicine colleague that we have a dementia patient, then their idea is this is a patient who is completely burnt out. That attitude needs to change, especially because this patient probably presented very early to you, maybe 2 months into his illness. So, and I'm not saying that this is not Alzheimer's. I'm just not saying that, maybe if we had intervened in a different way, it would have had a different outcome. But if we are keeping our antennas up to look for things that we could change, like, an autoimmune disorder, like, for example, we have seen this with anti-TPOs or steroid responsive encephalopathies, because he's pretty young for an Alzheimer's, he's in his 50s. He's not the 60, 70-year-old guy who's slowly progressive. So this is what is sticking me. I'm not saying I know the diagnosis. I'm just saying that when a person comes who's pretty young, who doesn't have a pseudo dementia and is rapidly progressive, then for me, my mental status is, oh, yaar, this is something that I should treat. And I will be very aggressive with him, meaning, I will look for all paraneoplastic markers. I will probably do a CSF and look for all the panels of infection that I would like to see, before branding him as an Alzheimer's. Because sometimes these diagnoses are almost like a death sentence to the patient, and coming from an MD physician from a reputed hospital would mean any other doctor they are going to follow up, that doctor is not going to change the diagnosis. I hope you're able to understand what I'm saying. For example, this patient goes to another GP outside with your diagnosis in hand, and that GP or anybody is not going to change the diagnosis or make an effort to make a different treatment or look at it differently. Are you getting what I'm saying? So
Yes.
my problem with this patient was that, have we gone a little ahead, or maybe could we have expanded our diagnosis base a bit simply because of this? Now, this form which I have right now is not a form that I've prepared for this patient. This is what we do normally when we see a dementia patient. This is the first form that we fill. If you look at it, if you look at the form, we have named it, just name, age, sex, and we are supposed to fill this up, so that we immediately look at those warning signs, the red flags, and say, okay, this is a rapidly progressive dementia in a young guy, and it is dementia, it's not pseudo. Are we missing something? Fine. Can you go into your clinical presentation? So this is the first process. So first thing that you looked at was whether it was dementia or pseudo dementia, and now you know it is not pseudo dementia, and it is rapidly progressive. Some of the things that we have looked at, some of the things we have not looked at, but it's okay. Let's go to your PowerPoint. Can you go into your presentation, please, if you don't mind?
Okay, sure, sir.
Can I share it? It's easier from here. Is this yours?
Oh, 1 second.
Is this yours?
Sir. We are sharing our PPT, sir.
Okay. I'm sharing your PPT only. Okay. Can you see my PPT? Meaning the one that you have sent?
Sir, could you stop sharing your
Of
your
course,
file?
I can. I've done that. Is this yours?
Yes, sir. This is mine. Can you
Fantastic.
see this? Okay.
Yeah, I can. So can you come down? So the first thing is 58-year-old man, Sari Taylor, since 8 months was unable to hold the needle and carrying away temple idols, correct? Very interesting history. So the first thing is unable to hold the needle. So what do we think it is? Meaning, do you think it is a motor problem, or do you feel it is a fine motor problem? It had to do more with grasp, or with it to do with fine movement? Because why am I talking about this? Now, at this stage, we need to differentiate whether it's a cortical type of dementia or a subcortical type of dementia. See, cortical dementias are dementias that are based on lobar functions like frontal lobe, temporal lobe, occipital lobe, parietal lobe. Subcortical are more like fine movements, coordination between the lobes. All those are subcortical. Example of a subcortical is your Parkinson's disease. Slow, processing becomes very slow. You ask him a question, he's going to take some time to answer, but the answer will be right. So you have put a slide that says that he's carrying away temple idols, and he's unable to hold the needle. Why am I talking about? So carrying away temple idols means that he doesn't have an insight, or he doesn't have that social stigma. No, I'm going to take that idol and run away, but it's inappropriate to do that. Now, have you seen children do this in temples? Picking some object and taking it home. Have you seen that? Child, maybe 2 years, 3 years. Do you see that? Picking something up from somewhere, getting it home, and then we scold them. Have you seen that?
Yes, sir. Yes, sir.
Yeah.
Why does that happen with a child, and why does that not happen with an adult? See, I'll make it a little more brash. Supposing a child is there, he or she wants to urinate or defecate. He might do it in a socially inappropriate place, but adults don't do it. Why don't we do it? The reason is because our frontal lobe is an inhibitory lobe. It develops that social skill, that what is appropriate in a social scene and what is not appropriate in a social scene. So carrying away temple idols, it means it's a frontal lobe involvement. You won't do it. Normally, I and we go to a temple, we won't take the temple idol and go away. Correct? We don't, right?
Yes, sir.
So that tells us that there's a frontal lobe involvement.
Yes, sir.
Now, what my interest was why was this patient not able to hold the needle? Is it because
sir,
that he... Go ahead. Sorry, doctor.
No, actually, sir, he's a sari designer by occupation. So he was not able to make those designs on the saris. He could not have the attention, or he could not even hold a needle. This is what
the intricate design, which is part of his profession, he was probably not able to do that. But I guess what it seems is it's a motor apraxia, and he is not able to do that. Probably that's, I don't know. Professor Sundar will tell us. Yeah.
Yes, that's really nice, because why I'm trying to tell you this, I'm just trying to broaden your horizon. See, supposing if you tell me that he is slow in his activity, but the design is good, that tells me it is a subcortical, like a Parkinson's patient. But if you tell me that he is unable to design it at all, then it becomes cortical. Are you getting what I'm saying?
Yes,
why are we talking about that? Because the reason why I'm talking about this, I'm sure, there are certain things that, we may not be able to get it as a very fine detail, but there is a pattern to it. A pure cortical versus a pure subcortical versus a cortical subcortical dementia has a pattern to it. And that pattern is very important, because as clinicians, we don't have access to, amyloid B proteins or a PET CT to do all these dementia workups and see and say, wow, this is a frontotemporal variant. No. Because as a clinician, you are expected to give a diagnosis bedside. So when you are talking about these things, imagine what I'm trying to say. See, now I'll tell you the next problem. Okay, so you have a patient who's probably having a frontal lobe involvement because he's taking away these idols and running away. And then you tell me that he's having a needle related problem, meaning whatever, he's not able to hold the needle and do. We'll assume that this is also frontal lobe. Maybe it is a frontal lobe. But the next part is a slurring of speech. Because when we are talking about speech here, again, cortical versus subcortical has a lot of difference. A subcortical, you've seen a Parkinson's patient, no, doctor? And the Parkinson's patient has a typically dysarthric speech. Whereas a frontal lobe involvement will have a dysphasic speech, word finding invalidity, language problems. So which are we dealing with? You getting what I'm saying?
Patient,
yeah, go ahead.
Sir, this patient had slurring of speech, but his comprehension and repetition was intact, and he had difficulty in naming his family member, even his son and wife. He couldn't call out their names. So we thought maybe it could be a nominal aphasia involving the temporal lobe. That also could be a possibility, because this patient did not have any other features to be called as Parkinson's, like bradykinesia, rigidity, tremor.
Agreed, doctor. So you are telling that this is predominantly cortical, so you are having a frontal lobe involvement, you have a temporal lobe involvement early, and you are saying that he is having a naming abnormality with some amount of language disturbances. Okay, lack of self-care. Again, this is very, very frontal, lack of self-care, lack of insight, lack of apathy, abulia, all those words we can drop in, but that means it's core frontal. And then it comes to inability to recognize friends, family, aggressiveness, visual auditory hallucinations. All that is okay. But there is one thing that I was finding, it that this dysarthria And along with dysphagia, which he developed a little later, I was thinking whether it was a bulbar component in it. Was there anything to say there was pseudo-bulbar? How was he emotionally? Was he emotionally labile? Was he withdrawn? Was he jocular? Was he happy, sad?
He was emotionally withdrawn, sir. He had apathy. He was isolating himself from conversations.
Very good. Okay. So you had this. So you had you started off like a frontal lobe involvement, primarily because you were seeing some motor apraxias or whatever that was there, and then he had this social inhibition that was going off, and then he developed a language disturbance. Then he developed hallucination, visuospatial. You were telling that he was wandering on streets. Why will somebody wander on streets? Maybe it had to do more with a visuospatial disorientation. Are you getting what I'm understanding? I'm trying to put the lobes here. So there is a frontal lobe involvement, there is a parietal lobe involvement, there is a temporal lobe involvement, but I don't know. But by history wise, whatever we are saying, maybe the subcortical involvement is not too much. Why are we talking about that? See, the pattern in which it is involved gives us an idea of what kind of dementia we are dealing with. If you have a frontotemporal dementia, there is a particular pattern. If you are an Alzheimer's, it is a difficult pattern. You have a frontoparietal involvement. If a corticobacillar degeneration has a different kind of pattern. And then if you see, then you say there is a dysphagia, urinary incontinence. Urinary incontinence is also primarily with a frontal lobe. You all know that. And then he became bedridden, and death was secondary to aspiration pneumonia. That's very, if you're really thinking of an aspiration here, that means there is a bulbar involvement later. I would like to know whether it was pseudo-bulbar or not, but whatever be the case, it has progressed. But the rapidity in which this has progressed is not fitting into an Alzheimer's. That's my issue. Can you go to the next slide?